This is a gross picture of ischemia. This is open intestine. This is the inside of intestine. The inside of the intestine demonstrate dusky black mucosa all over the mucosa secondary to ischemia, usually which results from hypertension and shock. Because the small intestine has a various blood supply and stomosing blood supply with collaterals. Usually this the involvement by so as to be involved by ischemia. It must have diffuse hypoperfusion secondary to generalized hypertension. This small intestine mucosa demonstrate marked hyperemia as a result of ischemic enteritis. Such ischemia must often result from hypertension, shock from cardiac failure, for example, from marked blood loss, hemorrhage, from loss of the blood supply, or mechanical obstruction, as with the bowel incarcerated into hernia with volvulus or into intussusception. If blood supply is not quickly restored, the bowel will be impacted and will result in necrosis. On closer inspection, early ischemic enteritis involves the tips of the villi. Why is the tips of the villi? Because it needs more energy for absorption, more ATP for pumps. So if there is generalized hypertension or ischemia, the pumps will be impaired and result in superficial ischemia. A colonoscopic view of ischemic colitis with minimal overlying exudate is shown here. In general, bowel is hard to infarct from atherosclerotic vascular nerving of thromboembolization because wide and stomosing blood supply. Small intestine has wide and stomosing blood supply, so it is usually the usual cause of ischemia is unlikely to be secondary to regional obstruction of blood vessel. Thus, most cases of bowel ischemia and infarction result from generalized hypertension and decreased cardiac output. This is endoscopic view demonstrating the edematous and exudative surface of the small intestine secondary to ischemia. This is microscopic view of ischemic enteritis secondary to hypertension, usually as the affected zone here, the mucosa are affected more than the underlying submucosa muscularis propria because the mucosa needs more energy for its function. So if the blood supply is decreased, it will not be able to sensitize ATP for its pump. So it will die secondary to hypoxia and vulnerable to necrosis. The mucosa surface of bowel seen here show early necrosis with hyperemia extending all the way from the mucosa to submucosa and muscular vessels. The submucosa and muscularis, however, are still intact, normal, because they are mesenchymal tissue and they can withstand the hypertension. Here is a closer view of necrosis, cell-less, slot mucosa, secondary to ischemia, higher magnification with more advanced necrosis. The small intestine mucosa shows hemorrhage with acute inflammation, in this case of ischemic enteritis. Here the dead tissue and here is the viable tissue. Those two glands are normal. Here the necrosed part. In the colonoscopic view below of the similar process in colon that in advanced, there is a time to yellow exudate overlying the erythematous mucosa. This is black. This is yellow zone here demonstrates the exudate secondary to inflammation. This view here, this is a small intestine. This is folds here, villi, and this is a tumor polyp here. It is yellow polypoid lesion in the small intestine, which is a common site for this type of tumor. It has characteristic yellow color on gross inspection. This tumor is called carcinoid tumor. Neoplasm of the small intestine are uncommon. Benign tumors can include leiomyoma, fibroma, neurofibroma, and lipoma. Seen here are ileocecal bulb. Here is another tumor that has a faint yellowish color. It has very characteristic yellowish color. This is a carcinoid tumor. Most benign tumors are incidental submucosal lesions, though rarely they can be large enough to obstruct the lumen. Here, this is mucosa, and this ulcer slab. These islands of carcinoid tumor from higher view. Here is a closer view, higher view. See, 4 or 6 nests of tumor cells having granular eosinophilic cytoplasm, round nuclei, and characteristic salt and pepper appearance of chromatin. At high magnification, the nest of carcinoid tumor have a typical endocrine appearance with small round cells having a small round nuclei and pink to pale cytoplasm. Rarely, a malignant carcinoid tumor can occur as large bulky mass. Metastatic carcinoid to liver can rarely result in carcinoid syndrome. Secondary to secretions of serotonin. This is yellowish tumor on the mucosa, found to be lipoma. This is another upper endoscopic view. Those are multiple polypoid lesions here and there, multiple small polyps. This one, and this one are small polyps. Those polyps are found to be hamartomatous on the biopsy, on histopathologic diagnosis, consistent with post-Tucker syndrome. Post-Tucker syndrome, syndrome characterized by multiple hamartomatous polyps and pigmented mucosa, and pigment on the mucosa, and increased incidence of carcinoma. Are rare autosomal dominant conditions that can be associated with polyps anywhere in the GI tract. Persons with syndrome have an increased risk of developing malignant neoplasm in various organs, but not directly with the polyp, within the polyps. This is more closer view. Those are multiple hamartomatous polyps. The diagnosis was post-Tucker syndrome. This is the gross appearance of fungating mass on the small intestine mucosa. Here are two parts of the fungating tumor. This is found to be metastatic carcinoma. The most common malignant neoplasm involving the small intestine is secondary disease or secondary cancer metastasis, as seen here. This mass causes local obstruction. Primary sites are often from nearby colon, ovary, pancreas, and stomach. This is the gross view of which is called carcinomatosis peritoniae, or seeding of the peritoneum. Those are multiple nodules on the surface of the small intestine and nodules in the mesentery with adhesions. This may result in small intestinal obstruction because the blood supply will be impaired. One pattern of intra-abdominal metastasis is so-called seeding of small tumor nodules onto peritoneal surfaces. The nodules are usually quite small, but larger masses can cause obstruction may occur. There is typically a large amount of ascitic fluid, عادة of exudative type, with positive cytopathology for malignant cells. And parasynthes can yield fluid which will demonstrate the malignant cell cytologically. This histologic appearance of metastatic adenocarcinoma. Here, poorly formed glands, solid form here, and these abnormal. This is the normal surface mucosa, and here is the metastatic malignancy, has irregular growth pattern, infiltrative growth pattern, hyperchromatic nuclei. This demonstrates a malignant growth of metastatic tumor. This adenocarcinoma arose in ampulla ovata, primary small intestinal carcinoma are very rare, but the majority of those do occur arise in the region of ampulla, where they may become symptomatic thoroughbiliary or pancreatic duct obstruction. So the presentation usually is jaundice. The appearance of such mass on esophageal gastroduodenoscopy is seen below. Is following placement of stent drainage. Here is a stent for drainage, and here is mass. This is normal mucosa here, and this is disfigured mucosa secondary to involvement by cancer. Other type of malignancy which can occur in the small intestine is leiomyosarcoma here. Leiomyosarcoma rising in a small bowel. As with sarcoma in general, this as big and bad sarcoma are uncommon as a site, but must be distinguished from other types of neoplasm.